Alright, so this is just going to be a review of the material for Exam 3. So Exam 3 is going to cover the information on bipolar disorders, which would be the second half of Chapter 7. The first half of Chapter 7 was on Exam 2. And then Exam 3 will also cover issues related to suicide, somatic disorders, and eating disorders. So we actually only had 3 lecture videos here. We combined bipolar disorder with the information about suicide. So briefly touching on some of the high points here, we said that bipolar disorder is contrasted with unipolar depression in that a person who has bipolar disorder also is experiencing some symptoms of mania. Now the slides listed several different symptoms for you, things like an increase in energy. We see people maybe having difficulty concentrating, their thoughts are all over the place, very intense emotions, that kind of thing. But one thing we said in particular that was the hallmark symptom of bipolar disorder would be a person having a lot of energy after very little sleep. So when we talk about mania, the term mania is technically referring to a person who is having a full manic episode, but it's also possible for a person to have symptoms of mania without it being severe enough to be classified as a manic episode. And so that's what we mean by the term hypomania. So bipolar 1 would be a combination of depression with a full-blown manic episode, at least one, and then perhaps more. Whereas bipolar 2 would include symptoms of depression as well as symptoms of hypomania, but the absence of actual manic episodes. If a person were to start having full manic episodes, then the diagnosis would switch to bipolar 1. So we talked about how people have different patterns of going through these mood episodes, but if a person has 4 or more mood episodes in a given year, we would consider that a rapid cycling bipolar disorder, which would be more severe, more difficult to treat. We talked about how in individuals who have bipolar disorder, they often have more depressive episodes, and the depressive episodes they have tend to last longer than the manic episodes. So to meet criteria for a depressive episode, the symptoms have to last for around 2 weeks, versus for a manic episode, it would be more like 1 week. Now, when we talked about gender, there was something interesting here where we said that bipolar disorder is actually found in equal numbers amongst men and women, which is interesting because when we talk about things like anxiety and mood disorders, we often see women being diagnosed more than men. However, there are some differences. Women tend to have more severe depressive episodes than men, tend to have fewer manic episodes than men, and may be more likely to have that rapid cycling type. Now, it's also possible that a person is having hypomania, so less severe symptoms of mania, combined with a more mild dysthymia-like depressive episodes. So in that situation where a person is having mild depression and milder symptoms of mania, we could consider the diagnosis of cyclothymic disorder, which could also be called cyclothymia. Now, there are many different thoughts about where mood disorders come from, but bipolar disorder in particular, because it does seem to be fairly genetic, is thought to have a large biological component. We talked about how, for example, this could be a neurotransmitter issue, about how individuals who are having both, we find low serotonin in both depressive episodes and manic episodes. So it seems like low serotonin opens the door for a mood episode to happen. However, the actual nature of the mood episode, whether it be a depressive episode or a manic episode, might depend on norepinephrine. So low serotonin, low norepinephrine, likely to have a depressive episode. Low serotonin, high norepinephrine, likely to have a manic episode. Alright, and once again, this is just a quick review, but as always, if you have any questions about the material, feel free to email me. So the other part of that lecture talked about issues related to suicide. So we talked about how it is difficult to have statistics related to suicide because sometimes it's not obvious if it was just simply an accident or if the death was actually by suicide. Remember that the term death by suicide is really preferred to a term like completed suicide because we want to take the negative connotation away, or rather we want to take the positive connotation away from completed and death by suicide focuses on the actual outcome of suicide. So being careful the way that we talk about it, but it is hard to collect statistics on suicide because individuals might have died by suicide, but it might look like an accident, or it could be that family members and friends, because it is difficult to have a loved one die by suicide, may not want others to know that that was the cause of death. When we talk about differences in suicide attempts between men and women, we see that women are much more likely to attempt, whereas men are much more likely to die by suicide. And one of the major differences here is that men tend to choose more lethal means, whereas women oftentimes attempt suicide using means like, for example, a drug overdose. And of course, when an individual attempts suicide with a drug overdose, there is a possibility that the body will reject that, maybe vomit that back up, or a person may find the individual and be able to get them to the hospital in time, and so it could just be a difference in the type of means that are chosen. We do see that individuals who are divorced or separated are at an increased risk for suicide attempt compared to individuals who are married. And we also saw that Caucasian Americans were much more likely to die by suicide, attempt suicide, than almost any other group. We did see that there is a very high rate of death by suicide among Native Americans, but that other minority groups tended to have substantially lower rates of suicide attempts, and that that's possibly related to the strength of family relationships and friend relationships. All right, we talked about how an individual might be at an increased risk because of things like long-term stressors. Now, there are too many things to put in this category for just a review video. But perhaps a person's career could be a long-term stressor. A person who, like, for example, a doctor or a psychologist. For example, someone who works with other people, sees a lot of suffering, maybe feels responsible for other people's outcomes, that kind of thing. Other long-term stressors could include health concerns that the individual has, maybe painful health conditions, as well as perhaps feeling like a burden on other people, or having relationship issues, kind of social isolation, that kind of thing. Now, sometimes we are able to see some changes in an individual leading up to a suicide attempt. Of course, we are not always able to recognize this, but what you may see is a change in mood and thought processes. So you may see a person who suddenly seems very agitated, maybe a person who seems depressed. There is a strong correlation between mood disorders and suicide attempts. Of course, there are some situations where a person attempts or dies by suicide, and to our knowledge and understanding, the person does not meet criteria for a particular disorder, but oftentimes the person does meet criteria, and things like mood disorders, psychotic disorders, substance use, that kind of thing can definitely increase risk. But you may see a person become preoccupied with death, maybe start kind of planning for things after their death, so giving away possessions, writing a note, that kind of thing. You may see people who are feeling hopeless about the future. Now, when it talks about the relationship with drug use, we do see that substances are often involved, even in individuals, there we go, who are not intending to attempt suicide by means of overdose, may still, for example, consume alcohol prior to an attempt. And so it may be a situation where the individual had already made up his or her mind to attempt suicide, and then the alcohol was just something to make that process a little bit easier. But it's also possible that a person may be on the fence, haven't really made up their mind, and then while under the influence of a substance, their mind was changed. So, briefly talking about treatment and prevention, if there is an underlying problem, an underlying mood disorder or psychotic disorder or other that we can recognize and treat, then that would also go a long way in reducing suicidal ideation. So having a person, suicidal ideation just means a person's considering and thinking about attempting suicide. Now, we of course would like to prevent as much as possible. We would like to prevent any attempts from happening. We are aware that It's not perfect. We're not always able to recognize people who are struggling, people who are considering suicide. But sometimes we have things like, for example, suicide hotlines where people can call and talk to someone who kind of does a crisis intervention where you develop a relationship, you try to help the person figure out what resources they have, help them make a plan to try to keep this person safe if at all possible. So crisis intervention, suicide hotline, that's usually not a professional psychologist conducting that. Maybe a person who has some training, has some experience, but not someone who technically has a degree, for example. However, if possible, it would be great to get an individual into therapy. Once in therapy, you would try to recognize what kinds of things trigger a person's suicidal ideation, what kinds of things can we do to try to reduce stress, to help them have a plan. If they start having suicidal ideation, what can we do? Who can we go talk to, spend time with? It's recommended not to leave a person alone. If there's anything that we can do to try to reduce stress in that person's life, that's very helpful. Also, reducing access to means is important. So typically a person who is considering suicide, if they've made it to that point of having a plan, then if you restrict their access to that means that they were considering, then they'll be less likely to attempt suicide with a different means. So, for example, if a person was intending to use a drug overdose, if we can limit that person's access to the medication, they'll be much less likely to try a different means. Of course, that's not definitive. Sometimes people do, but overall, people typically stick to their planned means. All right, somatic disorders refer to disorders that are psychological in nature, but they have physical symptoms. And so sometimes this is difficult to diagnose and difficult to do research on, because an individual who presents with physical symptoms, you might not automatically think psychological cause here. So even if we have individuals who have gone through intensive, significant medical testing and haven't found anything, there's still always the possibility that there is a medical issue that we just have not yet been able to recognize and find. So because of that, and because these disorders are rare, it's pretty hard to do research on these disorders. But we talked about, first of all, 3 disorders that are psychological in nature. So the cause here is psychological, but the symptoms are physical. So with factitious disorder, which is also called Munchausen syndrome, you have a person intentionally inducing the symptoms. Now, if it is factitious disorder imposed on self, or Munchausen syndrome, the person intentionally makes his or herself sick. If it's factitious disorder imposed on another, or Munchausen's by proxy is the other term for that, then the person tries to make another person sick. So oftentimes we see this with like a parent and a child situation. It's been a very long time since I watched The Sixth Sense, but I feel like there was some little side plot here where there was an individual that had maybe I can't remember. It could have been a family member, it could have been a nanny, I don't know, someone who was poisoning a child, and it was probably a Munchausen syndrome kind of situation. Been a very long time since I've watched that movie though, so don't quote me on that. Where does factitious disorder come from? It's hard to research. We don't know for sure. People often are not willing to admit that they have been doing this to themselves or to the other person, and so that makes it difficult, but it does seem to be associated with depressive symptoms, as well as having very unsupportive relationships with parents. So with factitious disorder, the person is intentionally inducing the symptoms. With conversion disorder and somatic symptom disorder, the person who is experiencing the symptoms, there's nothing they're doing to intentionally induce the symptoms. The symptoms seem to be happening on their own, but there's no known medical cause for them. So then the difference between conversion disorder and somatic symptom disorder is primarily the nature of the symptoms. So conversion disorder typically involves intense neurological symptoms, things like paralysis or loss of sensation, maybe blindness or seizures, that kind of thing. Now, of course, a person who's experiencing severe neurological problems needs to be checked out by a neurologist. But if we've been checked out by several different neurologists, done several different kinds of tests, and we can't find a biological cause, we might start to consider conversion disorder. And oftentimes, the way that conversion disorder is caught is that we will take the individual and look really closely at their symptoms and when those symptoms developed. And oftentimes with conversion disorder, there's something strange about the nature of the symptoms or about the timing of the symptoms that might suggest, hey, this is not the way the nervous system works. Maybe there's something else going on. Somatic symptom disorder is different because of the nature of the symptoms. The symptoms here they can include neurological symptoms, but rarely. They're much more likely to be things like chronic pain symptoms, maybe digestive issues, that kind of thing. But as with conversion disorder, this is an individual who's experiencing physical symptoms that they are not inducing in themselves. And so, of course, an individual who is having physical symptoms probably believes that it's a medical issue and may be very resistant to seeking out psychological treatment. So we talked about why this is difficult to do research on. We can't talk about somatic disorders without touching on psychodynamic or psychoanalytic viewpoint, which harkens back to Freud. Of course, Freud's early work with women primarily focused on women who at the time were diagnosed with what they called hysteria, which is similar to these somatic symptom disorders that we're talking about. So when a person had these symptoms, Freud would say, okay, well, what's going on here is that you have some very intense unconscious conflicts. And in order to try to repress that, to try to keep that out of your awareness, your body is producing these symptoms. So the symptoms, according to a psychodynamic therapist, would be there to distract the person from their underlying unconscious conflicts. And Freud, in particular, would say that those unconscious conflicts were probably sexual in nature. Now, the psychodynamic therapist might also suggest that there could be a secondary purpose here of a person having these symptoms because it gets them out of something that they don't want to do or gives them some kind of reward, but they would still say the main reason that the symptoms are happening would be to try to repress those unconscious conflicts. So the behavioral view would focus on what the psychodynamic individuals would call that secondary gain. The behavioral view is that an individual is reinforced because when a person is sick, when you are sick or someone you care about is sick, you get a lot of attention sometimes. You have individuals who give you money or they help you pay your bills or they come do your laundry and cook for you. And you may not have to do your chores if you're, child or whatever. May not have to do your chores, may not have to go to work, may not have to go to school. And so because of that, it is reinforcing to take on that sick role. That's not to say that these individuals are faking it, unless you might perhaps refer to factitious disorder as a person who's faking it. But someone who has conversion disorder or somatic symptom disorder, they're not faking it. But without really being aware of it, they've been reinforced for these sick behaviors, and that's causing the symptoms, or at the very least, making the symptoms worse. The cognitive viewpoint is that an individual is using their physical pain as a way to express their emotional pain. The idea being that a person does not know how to talk about or how to deal with emotional pain, but we do have some understanding of the right way to process and deal with physical pain. And so sometimes it may have, a very thin line between your physical health and your psychological health, which kind of carries on into what the multicultural individual might say, that in our culture, we tend to view physical health as being separate from psychological health, and maybe that's just not accurate. Maybe the fact that psychological pain causes physical pain should not be shocking or surprising to us. Maybe this is something we should expect. So it might have something to do with a bias we have in our culture. Now, with these previous ones we've talked about, these are disorders where a person is having physical symptoms. With illness anxiety disorder, previously referred to as hypochondriasis, a person is not actually having abnormal symptoms. If they're having any symptoms, the symptoms they're feeling are just part of normal life. Like you have heartburn sometimes, or you have a headache, or, you have a shooting pain in your left toe on occasion. But everyone experiences those things from time to time. No, my toe is not hurting at the moment, in case you're wondering. But no, the idea is that a person who has illness anxiety disorder, if you already are a very naturally anxious person, might pick up on some of those little cues that basically just mean you're alive and become very anxious about them. And of course, the more anxious you are about something, the more severe it seems, and then you start Googling things or doing research, and there's always a scary story out there. So be very careful of Dr. Google. All right. Psychophysiological disorders refer to an individual who genuinely has a medical condition, but that medical condition is complicated or maybe made worse by psychological conditions. So there are many different conditions that if an individual has those and at the same time has depression or anxiety or substance use or any other number of psychological problems, that can make the medical condition worse. So, for example, if a person already has high blood pressure, but then has an anxiety disorder as well, or a person already has insomnia, but has depression as well. So we listed different things like ulcers and asthma, different things that are genuinely physical, psychological factors involved, but they're genuinely medical issues. And so then when you're talking about how to treat those disorders, you want to see both a medical doctor who can treat the actual medical cause, but also perhaps a psychologist that can help with the psychological factors that are making that disorder worse. So if you have asthma and an anxiety disorder, then in addition to seeing a medical doctor and getting an inhaler and following whatever your doctor tells you to do, you might also want to seek out treatment for an anxiety disorder that could trigger asthma attacks or make the asthma attacks worse. All right. So when we're talking about psychological treatments, briefly here, we talked about things like relaxation training or meditation. We talked about some cognitive interventions about having people change the way they think about their medical condition. We talked about perhaps some stress inoculation training, preparing people to deal with stress, maybe do some deep breathing or some progressive muscle relaxation so that the person is able to calm down and, at the very least, minimize the symptoms as much as possible. All right. And then the last section was on eating disorders. So we talked about how eating disorders are different from a lot of other disorders in that they are not culturally universal. So we do not find them in equal levels everywhere. That eating disorders are a very Western issue. And perhaps that has to do with the pressure on our culture to look a certain way, but also, of course, it has to do with the access to food as well. In cultures where food is less available, we don't typically see things like eating disorders. Now, when we talked about eating disorders, we touched on 3 major diagnoses: anorexia, bulimia, and binge eating disorders. So, anorexia happens when an individual is purposefully restricting diet to the point that a person is 85% or less of what we would consider typical body weight. So the individual who has anorexia is having that kind of self-starvation. The individual with bulimia is a person who has a pattern of binging and then purging or engaging in some kind of compensatory behavior, which could be a purge, but could also be things like fasting or excessive exercise. And then binge eating disorder happens when you have the binges like we see in bulimia, but you don't have the compensatory behaviors, so things like vomiting, misusing laxatives, excessive exercise. You don't see that in binge eating disorder, but you do in bulimia. Now, we did talk about how there are a lot of similarities between anorexia and bulimia. Usually we have a person of a typical weight or perhaps slightly above weight in the beginning, and then the individual goes on a diet, and then that combined with some kind of stressful life event can start this negative cycle. We talked about how individuals who have eating disorders often have other comorbid disorders, things like anxiety disorders, OCD in particular, but perhaps also substance use disorders and others. Now, we did talk about how individuals who have anorexia have different medical problems than people who have bulimia. So individuals who have anorexia are more likely to have fertility issues, so a woman is more likely to stop menstruating. That happens almost all the time with anorexia because of the significant loss in body fat. Whereas an individual who has bulimia, although they are having an eating disorder, they are probably on average in a pretty typical weight range. Their weight probably fluctuates pretty wildly, but on average they're in a pretty typical weight range, and so they're less likely to go through that loss of menstrual cycle, although it can still happen and does still happen. So the medical conditions are different then, because an individual who's experiencing bulimia will have some issues related to the type of purging that they're doing. So if a person is vomiting, that's not good for your teeth, not good for your esophagus, for your digestive tract. And we also talked about how a person who engages in purges like that may lose the ability to feel satiated or to feel satisfied with food, and then that can just make things worse. We also talked about how individuals who have bulimia tend to be a little bit more worried about pleasing other people. And so this may be a person that is attempting to control their weight for another person, to look a certain way or to please another person. Whereas a person with anorexia may be more likely to do that because they personally enjoy the sense of control. It's not really as much for other people as it is for themselves. Now, when we talked about binge eating disorder, we're talking about individuals who are engaging in those binges, which is a substantial amount of calories being consumed in a short period of time. Usually the kind of food that goes down easily, something soft, something sweet, is oftentimes involved. And both with people who have bulimia and with binge eating disorder, the binges are likely to be carried out in secret, so a person may not let on that they're experiencing this. Now, we do see that the majority of people who have binge eating disorder are overweight or obese, but not everyone who has binge eating disorder is. And that may have to do with the severity of the symptoms or with the person's particular metabolism, that kind of thing. Now, risk factors for eating disorders, we already know that there are psychological issues related, so we talked about things like depression, anxiety, OCD, perfectionistic tendencies, maybe a personality disorder. But then there's also a strong biological connection. There's a genetic connection, especially with anorexia, but with bulimia as well. And that's thought to be related to serotonin issues. And we talked about how in our culture we tend to value a very thin body type, about how, for example, Playboy centerfolds and the Miss America contestants are getting thinner every year. And so individuals who are exposed to more social media and other things on the internet and television may be a little bit more at risk. So we talked about how young girls are dieting at very high percentages, and perhaps it's because of something in our culture. Now, how do we treat eating disorders? Well, it depends on the specific disorder as well as the severity. Our goal would be to try to improve a person's health as soon as possible. So, for example, a person with anorexia may be in a life-threatening position when the individual gets into treatment. So people often suffer from eating disorders for quite some time before they are either they seek out treatment themselves or another person insists that they go to treatment. So an individual who has anorexia may be experiencing major health concerns, and in that case it may be required for us to do something like feeding the person through an IV, force feeding the person, which is not ideal, but maybe something we have to do to save a person's life. So try to reduce whatever health risks are associated and trying to figure out what the underlying issue is, whether you have a certain thought process about yourself or about food, or maybe it's just reinforcing for you, it's where you find your sense of control. So helping the person identify the underlying problem and treat that would be a good place to start. Now, our settings, most of our therapy that we do at this time in general is in an outpatient basis, but depending on the severity, it could be inpatient. If a person has very significant health concerns, they're probably in a hospital. So the setting would depend on the severity. But cognitive behavioral therapy would focus on changing attitudes about yourself, attitudes about other people, attitudes about your body and about eating and about exercise, as well as a behavioral component of reinforcing people for achieving a healthy weight, reinforcing people for appropriate eating and exercise behaviors. Now, what we see is that eating disorders are tough to treat. Anorexia in particular has a lot of risks associated with it. So people may die from complications of starvation, or are also at an increased risk for suicide attempts. So when we're taking a severe case to begin with, that does impact the outcomes of therapy. The more severe the problem is going into therapy, the harder it is to achieve a full cure, or at least to reduce those symptoms completely. So we do see that there usually are benefits to individuals who have treatment. We may want to combine the therapy with a medication, because there's been some suggestion that serotonin may be an issue with eating disorders, so maybe combining it with an SSRI. But we would also want to monitor a person, even if the person has had some success in therapy, because there is a high risk of relapse. We would want to maybe see a person every few months just to check in, or at the very least have a relapse prevention session where you talk to the person about what symptoms will let you know that it's time to come back to therapy. At what point do you know that you need to make a change when you see these symptoms start coming back in your life? Alright, so this has just been a quick kind of casual overview of the material for Exam 3. So let me know if you have any questions. Otherwise, I will talk to you guys after Exam 3.